We welcome you to our module Rheumatoid Arthritis and Inflammatory Connective Tissue Disease, HCC40 from MRA Tips. This module has been developed specifically for MRA reviewers as a refresher on diagnosis criteria, documentation, and coding of rheumatoid arthritis and inflammatory connective tissue disease. At the end of this module, the learner will be able to define and differentiate among spinal enthesopathy, facet arthropathy, and spondyloarthropathy. Discuss the criteria for the documentation of these diseases. Note the ICD-10 codes for spinal enthesopathy, facet arthropathy and spondyloarthropathy. Review the example of the assessment and plan for the diseases. Spinal enthesopathy, facet arthropathy and spondyloarthropathy come under the umbrella of inflammatory rheumatic diseases. Rheumatic diseases affect joint tendons, ligaments, bones, and muscles. Spinal enthesopathy is a disorder at the site of the insertion of ligaments, tendons, fascia or articular capsule into bone or enthesis. It is a result of an inflammatory rheumatic or non-rheumatic disease process. It can develop at any joint or the junction of tendons and bones. This process also may promote abnormal calcification or ossification of the tendon or ligament at the insertion into the bone. The common sites where enthesopathy occurs include heels, fingers, toes, elbows and backbone. Usually, repetitive movements such as running can cause this disease. Other causes include trauma, autoimmune diseases and genetics. The major symptoms are joint stiffness and swelling in the affected feet or leg. Facet arthropathy, on the other hand, refers to a disease of the facet joints. It is also called lumbar facet arthropathy and lumbar facet arthritis. In this, the protective cushion made up of cartilage between the facet joints degenerates due to wear and tear, resulting the joint bones to rub together or not move as they should be moving, causing pain, swelling and stiffness. The symptoms include pain in the back or neck that gets worse when bending or leaning backwards. Spondyloarthropathy, sometimes referred to as spondyloarthritis, is a group of inflammatory rheumatic diseases that includes ankylosing spondylitis and psoriatic arthritis. Ankylosing spondylitis is primarily characterized by chronic inflammation of the joints and ligaments of the spine, while psoriatic arthritis is associated with psoriasis, which is a skin condition characterized by red, patchy, raised or scaly areas and chronic joint symptoms. The predominant symptoms among them are joint pain and inflammation, sometimes affecting the spine. They are linked by their association with the HLA-B27 gene and by the presence of enthesitis as the basic pathologic lesion. The criteria for the documentation of these diseases include a physical examination showing positive results for pain, diagnostic and lab test. The physical examination for spinal enthesopathy should check for pain in lumbar, dorsal or cervical spine for over 40 years. The pain should have had an insidious onset of more than 3 months. The examiner needs to clarify whether it is associated with morning stiffness and improves with exercise. For spondyloarthropathies, the examiner should check for inflammatory back pain, dactylitis, and extracurricular manifestations such as uveitis and skin rash. For the diagnosis, an X-ray, a CT scan or an MRI test may be used to help diagnose facet arthropathy. While the supporting laboratory findings should include absence of rheumatoid factor, elevation of the erythrocyte sedimentation rate, ESR, or C-reactive protein, CRP, level, and presence of anemia of chronic disease. Note that HLA-B27 testing is of limited value here. The synovial fluid typically is inflammatory, more than 2,000 white blood cells per milliliter, with a predominance of neutrophils, but this finding is nonspecific. Let us look at the ICD codes involved with these inflammatory rheumatic diseases. For spinal enthesopathy, when the site is unspecified, the code is M46.00, and when there are multiple sites in the spine, the code is M46.09. Their HCC code is 40. For other infective spondylopathies of unspecified site, the code is M46.50, HCC 40. For ankylosing spondylitis of multiple sites in the spine, the code is M45.0, and if the site in the spine is unspecified, the code is M45.9, their HCC codes being 40. For other specified inflammatory spondylopathies, with multiple sites in the spine, the code is M46.89, HCC 40. For unspecified inflammatory spondylopathy, with unspecified site, The ICD code is M46.90 and lastly, when the site is in the lumbar region, the code is M46.96, with the HCC value of 40. The assessment and plan should address the diagnosis and include 2 support indicators. It is essential to document specific factors for the specific arthropathy being diagnosed, for example osteoarthritis versus psoriatic or other arthropathy. Let's see an example of a progress note. Patient name: Casey Henderson. Date of service: May 12, 2019. Date of birth: December 4, 1942. Assessment and plan: Unspecified inflammatory spondylopathy, lumbar region. Pain continues despite physical therapy and ibuprofen 800 mg up to TEAD. MRI of lumbar spine and referral to neurosurgeon. Return to office in 3 months. We have reached the end of our short refresher course on rheumatoid arthritis and inflammatory connective tissue disease. We gave you a short introduction to the diseases, identified the criteria involved in diagnosing the diseases, their ICD codes, and finally reviewed the assessment and plan for rheumatoid arthritis and inflammatory connective tissue disease. Thank you for joining us.